Hello, everyone. And today we have Emily Leung, who is a final year medical student at the Medical School at University of WA, being kind enough to presenting a long case today. So I might just get Emily to kick on and present the long case straight away. Then at the end of the video, or maybe a separate video, we'll do a little critique on all the great things she's done and maybe some things that could be improved upon to make it better. And hopefully this will give you an idea of how to take a history and how to present a long case. So Emily, are you ready to go?
Yes.
Perfect. Okay, whenever you want, start away.
So Mr. Smith was a delightful 54-year-old gentleman who came in yesterday with a sore tooth and gum infection of 4 days duration and a severe neutropenia with a white cell count of 0. All of this is on a background of a double liver and kidney transplant in January this year for autosomal dominant polycystic kidney disease, and he's immunosuppressed on tacrolimus, mycophenolate and prednisolone. So this started on last Saturday, which was 4 days ago, when he noticed a pain in his lower right gum and tooth. He also noticed some white slough around the gum. He saw his dentist on Tuesday, who cleaned the tooth, gave him oral Augmentin, and he also on that same day took his follow-up bloods for his transplant clinic appointment. The nurse from the transplant clinic called him to tell him that his white cell count was 0 and that the doctors asked that he present to Sir Charles Gardner Hospital. He notes that this infection was at the same site of a gum infection that he had 3 weeks ago. This previous infection resolved with 1 week of oral metronidazole given to him by his dentist. He thinks that the original trigger for these dental infections may have been some trauma from seeing his dental hygienist for a clean a few weeks earlier. Other than the sore tooth, he's feeling totally well, and he even went to the gym on Monday. He denies any subjective fever or rigors, and he has no other localizing symptoms of infection. So there's no coryza, cough, shortness of breath. He's had no infectious contacts. He's had no dysuria, change of bowel habit, no itch or rash, and he's noticed no leg swelling. Since his transplant in January, he's had no other infections other than these 2 that I've mentioned. So his post-medical history has an interesting course. He was diagnosed with hypertension in his 20s and was put on metoprolol. However, this was never investigated any further. He was diagnosed with autosomal dominant polycystic kidney disease in 2013. This was an incidental diagnosis on a CT colonoscopy. He reported that his initial kidney function was around 60% at diagnosis. In 2017, he was started on tolvaptan in the UK, where he was working at the time. In the years following, he had a few admissions to hospital for cyst rupture and for infected cysts. And in 2022, he had a preemptive right nephrectomy at Fiona Stanley Hospital due to pain from ongoing cyst rupture. This operation was complicated by a significant intraoperative hemorrhage that required CPR in theatre. Unfortunately, after this operation, his liver grew significantly in size on a follow-up scan, and he had ongoing abdominal pain. However, he had no clinical hepatic impairment. After this operation, he was also started on hemodialysis. In January of 2024, he received a deceased donor kidney and liver transplant. This was an otherwise uncomplicated operation, and he only required 18 days hospitalisation, and he had a short period of hemodialysis during this inpatient stay. However, he was discharged and was not requiring hemodialysis afterwards. Since that operation, he says that he's been the best he's ever been. So in terms of his follow-up post-transplant, he's been on immunosuppression, as I mentioned, and just checking in with some of his steroid issues. His blood pressure has been maintained at about 130s systolic. His sugars have been well controlled and are monitored by his GP. He was osteopenic on his preoperative DEXA scan. However, his bone mineral density has since improved. He did have some initial sleep problems with the steroids, but these have resolved over the last couple of months. His other past medical history, he's had 2 BCCs removed. However, his GP has noticed a recurrence of one on his right chest, and dermatology will be seeing him as an outpatient to remove this. He was also diagnosed with an intracranial aneurysm in 2021. This was again picked up incidentally. He's known to the neurointerventional radiologists at Sir Charles Gardner, and they elected for no intervention, and he's been stable on all their follow-up MRIs. His other past medical history includes gout in the past, but he hasn't had flare-ups for years. He's not on any medication for this. He had a DVT 10 years ago provoked by a long flight, but has had no issues since. And he also has had anxiety in the past, but has denied any symptoms of this recently. His family history, his father had an episode of glomerulonephritis requiring cyclosporin, and there's been no family history of polycystic kidney disease. He's an only child. His grandmother did have bowel cancer in her 60s, but she did not die of bowel cancer. He has no known allergies, and his medications, as I mentioned, he was on tacrolimus, 2 milligrams twice a day, mycophenolate, 250 milligrams twice a day, prednisolone, 10 milligrams daily. He's also on Valgan cyclovir for CMV prophylaxis, 450 milligrams daily. His dentist started him on Augmentin, as I mentioned, twice a day. He's on pantoprazole, 40 milligrams daily, pravastatin, 20 milligrams daily, aspirin, 100 milligrams daily, caltrate and vitamin D daily, and he was started on filgrastim, 300 micrograms daily in hospital. He was also put on enoxaparin, 40 milligrams daily, and TED stockings for venous thromboembolism prophylaxis. As for his social history, he reported occasional social smoking in his 20s, but said he was never a regular smoker. For alcohol intake, he said he drank at least 20 standard drinks per week for a couple of decades from his 20s to his 40s, but he's had very little alcohol at all since 2022. He denies any other drug use. For work, he is an accountant, and part of this work at an international accounting firm has meant that he's travelled to many third world countries to give talks at conferences, but he denies any history of hepatitis, TB or HIV, and he said that illness that he's acquired abroad has been diarrheal only. He now works for the same company but at home in Australia. The company is based in London. He lives with his 2 parents, who are both in their mid-80s. His parents are well and very supportive of him. He and both his parents are all independent with their activities of daily life, and they all are able to drive. He is able to drive himself to his medical appointments. He loves yoga. He goes to the gym 3 times a week, and he walks about 6 to 7 kilometres every day. He's also denied any low mood or any symptoms of anxiety, as I mentioned, and he says he's been sleeping well, his appetite is good, and he's generally feeling very good, and his friends have reported that he seems better than he ever was. On examination, he was a bright and chatty gentleman who was actually walking in the corridor when I met him. Importantly, he was afebrile. His blood pressure when I reviewed him was 135/75, heart rate 88, respiratory rate 18, and he was saturating above 94% on room air. On inspection of his teeth, his right lower second premolar had a small area of slough just at its base, and there was a tiny peeling back of the gum beneath the tooth. However, there was no swelling or erythema, and his other dental hygiene appeared good. There was no local lymphadenopathy. On examination of his chest, his heart sounds were dual and his lung fields were clear. There were no crackles or dullness to percussion. There were no signs of liver disease, significantly no bruising, no spider nevi, and no ascites. There are also no signs of anemia. He was euvolemic with moist mucous membranes, a cap refill of 2 seconds, and he had warm peripheries. There was no sacral or pedal edema, and as I mentioned, no crackles in his lungs. He had an arteriovenous fistula on his left forearm, and the thrill was present. On examination of his abdomen, he has a large chevron scar, as well as a large midline scar, and a scar in his right iliac fossa. There was no abdominal distension, no ascites, no hernias, no hepatosplenomegaly, and his transplant kidney was palpable in the right iliac fossa, and there was no tenderness either over the transplant kidney or in the rest of his abdomen. So overall, my impression is that he's a 54-year-old gentleman, 6 months post-renal and liver transplant with severe neutropenia, afebrile, but with a possible dental infection. So he has several acute and long-term issues. His acute issues are, number 1, his neutropenia and immunosuppression. Number 2, his dental infection. And number 3, just to consider while he's in hospital, his past history of DVT. So he'll need to be on VTE prophylaxis. Long-term issues to consider with him are his ongoing immunosuppression, which places him at increased risk of cancer, such as his BCC recurrence. Important to note that his grandmother had also had bowel cancer in her 60s. And he's also at increased risk of infections. As he'll be on long-term steroids, important comorbidities to consider will be osteopenia, diabetes, cataracts, hyperlipidemia and weight gain, as well as gastrointestinal ulcers and bleeding. Being a liver and kidney transplant patient and having been on hemodialysis, he's also at increased cardiovascular disease risk. So he'll need monitoring for this with his lipids, blood pressure and blood sugars. The long-term function of his both renal and hepatic grafts will also need to be monitored. And just social long-term issues. He is currently living with his parents who are very supportive of him. And whilst they are well and independent, they are in their 80s. And whether they would still be able to support him in, a decade's time, were he to have any problems with his transplants down the track, is something to consider. And just considering his mental health as well. Whilst he was well on my review of him, he has had anxiety in the past and he does have a high a burden of chronic disease. I guess for me, the most interesting thing considering his presentation would be the cause of his neutropenia. So things to consider is this neutropenia secondary to the medication he's on, such as the mycophenolate and the valganciclovir? And if so, why has this caused his neutropenia now? So could it be from drug-drug interactions with the metronidazole he was on recently, or has he had declined renal function from perhaps transplant rejection?
So staying with that, sorry to interrupt, Emily, but staying with that, what has the dosing been like for his mycophenolate?
So his mycophenolate is currently, he's on 250 milligrams. I believe it's been stopped since he's come into hospital.
But prior, I guess as testing your hypothesis that could be the cause of his neutropenia, has the dose been increasing? Has it been decreasing previously, or what's been happening?
I'm not sure actually what's been happening previously.
Okay. Yeah. And what about the valganciclovir?
Same. I'm not sure whether that's been changed previously. Okay. Yeah.
And then why has he got gum problems now? Has he had a history previously of gum disease, or did he have dental clearance prior to the transplant, for example?
So he did say that his dental clearance prior to the transplant was good, and since then he's been very vigilant with going to his dental checkups. As I mentioned, his dental hygiene as a whole looked impeccable apart from this one area, and he says that he thinks it may have been from having the dental hygienist about a month ago sort of scraping at his teeth and his gums, which may have precipitated infection.
So if your hypothesis is that the neutropenia, which is one of your key acute issues is due to the mycophenolate and the valganciclovir. What do you think you could do about that?
Well, considering he's about 6 months post-transplant, I believe that valganciclovir is usually only given for 6 months prophylactically. This could be ceased early, and the mycophenolate could be also reduced. But if you reduce the mycophenolate, you may need to increase doses of his other immunosuppression to make sure that his graft function is maintained.
Okay, good. So, I mean, likelihood is he will get over this acute event and be discharged, and his neutrophil count will settle. What do you think his biggest long-term risk is going to be for his health or survival?
I think cardiovascular disease risk, given his, he's been in chronic kidney failure in the past, and he's been on hemodialysis. He's a kidney transplant patient. Other things, because he's on steroids long term, will be from risks from infection, and also
what are his major cardiovascular risk factors?
He's been hypertensive since his 20s. I'm not sure about the control of this since his 20s, but he did say that he was put on valsartan as well as the metoprolol. Given that he's on steroids, he's at risk of weight gain, diabetes, and hyperlipidemia.
What's his weight like at the moment?
His weight, he's currently 82 kilos, and he has been about that since his operation, and he's over 6 foot, so his BMI is normal. Okay.
So if we think about the blood pressure, we're focusing on the blood pressure, then what kind of blood pressure target do you think you'd be aiming for?
Given that he's a renal transplant patient, I think more aggressive blood pressure target of 130 systolic, 130 on 80, rather than our sort of typical 140 GP.
And you mentioned a few medications that he's been on in the past. Did he have any problems with the medications, and what is the control of his blood pressure been like previously?
He mentioned that he didn't mention any problems with his medications, and he certainly seemed very on top of all of his medications. But as I mentioned, he was started on metoprolol in his 20s. He said that, about 10 years after this, he had to start on an additional agent, valsartan. Interesting, I guess, to note that now metoprolol or beta blockers are no longer first-line agents for management of hypertension.
Okay, so his blood pressure was a bit higher than your target today, and if it were to remain that high or higher, you would start him on the medication?
Yes, he's given that he's not currently on any antihypertensives.
What would you give him?
ACE inhibitors are renoprotective, so this could be something to consider, but you'd want to make sure you check his renal function and electrolytes before starting this. And obviously, I think this would be a decision that either his transplant team, whether it be the liver or the kidney physicians, to look into.
Sure. Okay. And I noticed he's living with his elderly parents. Is there a reason for that? Has he got financial issues?
As far as I can tell, no. He says he's still been able to work, and he's quite senior in this firm. He's been working for them for decades, so he's working online. As far as I could gather, as he was living in London prior to his transplant and moved to Australia, I think because he thought it would be easier to get a transplant. And he moved in with his parents when he moved back. They helped look after him after the transplant. So as far as I'm aware, it was a situational move to go back with his parents, but there's no financial issues.
Oh, okay. And does he have a relationship, children?
He has no partner and no children. No.
Okay, good. Well, I might end your torture there, Emily, and thank you once again for helping us out and demonstrating how to present a long case. And we just might end it there.